Robotic knee replacement. Patients ask me about it almost every day. Some of them want the robot, some of them are afraid of it, and everybody wants to know the same thing. Does the robot actually give you a better knee? Here's my honest answer. The robot changes what I can do in the operating room today for every single patient, but the long-term data, it's still early. And everyone who tells you it's already settled is getting ahead of the science. So let me walk you through what the robot actually does, what the evidence shows so far, and what I tell my own patients. I'm going to tell you just like I would tell you if you were sitting across the desk in clinic with me. First, the most important thing I can tell you, the robot is a tool. It doesn't make decisions. It doesn't operate on its own. The robot does nothing without me. Every clinical decision in your surgery is still mine. Think about it like GPS for your car. GPS gives you better information. The good ones even adjust to traffic in real time. But GPS is not driving the car, and even a self-driving car wouldn't tell you where to go. That's the robot in my operating room. It gives me better information so I can make better decisions, and it helps me carry out those decisions with precision. The judgment stays with the surgeon. It has to. So what does the robot actually change? I think about it as offering 3 pillars, and here's how I explain it to my patients. A 3-legged table can't wobble. There's an old principle in geometry that between any 3 points there's a single plane. That's why a 3-legged table can't wobble. Robotic surgery done right stands on these 3 legs. Pillar 1, start with the truth. Before your surgery, we get a CT scan of your knee, not just an X-ray, a full 3-dimensional picture of your actual anatomy. I call that anatomic truth. Your surgical plan gets built on your knee, not an average knee, not a template, it's yours. The second pillar, the ability to adjust intraoperatively to you. Here's what no scan can tell us ahead of time: how your ligaments actually behave dynamically now. Every knee has its own ligament tension. Some are tighter, some are looser. And for a knee replacement to eventually feel normal, feel like your own, it needs to be well balanced against your specific ligaments. During surgery, I can measure that tension and fine-tune the plan right there to fit the plan to you. Why does that matter? Because balance is what a knee replacement actually feels like to you. Too tight on one side and the knee feels stiff. Too loose on the other side and it will feel wobbly to you. It's just something you can't fully trust. If we get that right for you, if we get those ligaments right, it's a huge part of allowing your knee to feel like your own. That type of customization simply didn't exist earlier in my career. We used to find out how your ligaments behaved, but we'd have to do our best with jigs and our eyeballs to make sure that we got it right for you. Now we can measure it and adjust the plan with real numbers. And that brings us to the third pillar, execution. If you have a perfect plan, it's largely worthless unless you can carry out that plan precisely. That's where the robotic arm earns its place. It helps me execute the plan that I just made to your knee, with an accuracy that hands and mechanical guides alone simply can't match. So there it is, the 3 pillars: truth, adjustment, and execution. 1, 2, 3. A 3-legged table can't wobble. That's what the robot changes in my operating room today. Now let's talk about the fear. I had a patient not long ago who asked me directly not to use the robot. She was worried it would take over, that somewhere in the operating room she'd lose her surgeon to a machine. I understand that worry, and I told her what I'm telling you. All the decisions are mine. The robot is an instrument in my hands. It does nothing on its own. Her fear wasn't foolish. It was just a misunderstanding about how this technology is used. And she's not alone. I hear a version of this question every month. So if that's your fear, let it go. You're not trading your surgeon for a robot. And here's what the robot actually looks like from your side of things. 1 extra appointment before surgery for a CT scan. That's it. On the surgery day, the robot is an extra piece of equipment in the room, the same way the lights are or the other instruments we use. You won't really see anything different. And you won't feel anything different. The difference is in the information I'm working with while you're asleep. Does all of this give you a better knee? Here's where I want to be fully straight with you. The data is still early. There is data showing early clinical benefit, and surgeons who use robotics see why. Better information before surgery, real adjustment during surgery, and precise execution of their plan. But whether that changes your outcome, say 10 or 20 years down the road, we still don't know. It hasn't been proven out in the literature, but I believe it will. I wouldn't use it on every knee I replace if I didn't, but I won't claim it does before the data's in. What I can tell you with confidence is this: the robot changes your surgery today. It helps me be a better surgeon today, and I believe that helps every single patient that's on my OR table. The next step for all of us in this field is connecting those better decisions in the operating room to the long-term results that patients actually feel. We need to measure it. We need to make it objective. That's where this technology is headed, and it's worth being excited about. Now, here's the part that bothers me. You see the word robotic on a billboard, and it sounds like they're all the same. They're not. Not every robotic platform starts with a CT scan. Some skip that anatomic truth entirely. So the word robotic by itself doesn't tell you that those three pillars that I believe so much in are actually there. If you're evaluating a surgeon and robotics comes up, it's fair to ask three simple questions. Does my plan start with the CT scan of my knee? Or maybe an MRI? Can you adjust that plan during surgery based on my ligaments? And does the robot help you execute your plan? Those three legs. If one is missing, the table can wobble. One more thing, and it might surprise you coming from someone who uses the robot every day. I've used the Mako platform since 2014. When the Total Knee system launched in 2016, we were part of the limited market release, one of the first centers in the country doing robotic total knees. So yes, I do believe in this technology. I use it on every knee replacement. I do. But listen, if your surgeon doesn't use a robot, that does not make them the wrong surgeon for you. Robotics is not the standard of care, at least not yet. And anyone who tells you something different is not telling you the full story. A surgeon operating the way they're most comfortable will give you the best result. Don't push your surgeon to use a tool that they don't use typically. Trust your surgeon, or find one that you can trust. That relationship matters even more than any machine in the room. And if you're wondering how fast you'll be back on your feet afterwards, I've covered recovery in detail in other videos, so I'll leave that story there. So here's the short version. The robot is a tool, and a powerful one. 3 pillars: start with the truth, adjust the plan to you, and execute with precision. The early data is encouraging. The long-term data is still being written, and the surgeon holding the controls matters more than the robot. If you want to go deeper, I wrote a full article on what the data actually shows. The link is in the description, along with how I combine robotics with a muscle-sparing approach, the Submastis approach. And if you're facing this decision for yourself and you want to walk through your own knee, the link to schedule a visit is down in the description too. Do you have a question about robotic surgery that I didn't answer? If you drop it in the comments, I'll read it. I read them all. Thanks for watching.